Hello, everyone. My name is Associate Professor Dr. Narisha Chirakawasan. I'm from Chulalongkorn University, Bangkok, Thailand. And my topic is going to be obesity hypoventilation syndrome. So this is the outline of my talk. I'll be talking about pathophysiology, clinical presentation, diagnosis, and treatment. So let's start with pathophysiology. First, the alteration in respiratory mechanics. So that is the excess of adipose tissue in the abdomen and surrounding chest wall, which will reduce the lung volume, including the reduction in ERV and FRC. There is also expiratory flow limitation as well as intrinsic passive and expiratory, particularly during supine position. There is also REM sleep hyperventilation, which occur in OHS, owing to a combination of obesity-related mechanical constraints affecting the function of the diaphragm and reduction in central respiratory drive. So this is the figure that I authored in the textbook hosted by Thai Asthma Councils. So on the left, this is the obese patient, and on the right is the normal individual. So you can see in the obese patient, that is reduction in total lung capacity, reduction in expiratory reserve volume, and also there is reduction in airway diameter. And the reason for reduction in airway diameter can be explained in these two figures. So on the left, this is the normal individual in which we have a negative intrapleural pressure around -10 at the apex and around -3 at the base. So when you're obese and you have reduction in lung volume, so you have the overall reduction in negative pleural pressure. So at the apex, when you start with more negative values, the pressure remains negative. However, at the base, the intrapleural pressure might change into a positive value, and it can cause compression of the airways, resulting in airway closure. Next, there also reduction in respiratory drive. So that is normal physiology with sleep-related reduction in respiratory drive. However, leptin is also acts as a powerful stimulant of ventilation in OHS. However, in OHS, there is leptin resistance. And there is one major OHS phenotype with obesity with significant impairment in respiratory mechanics, severe hypercapnia, and typical REM sleep hypoventilation. And this OHS phenotype tends to respond more to the NIV. So there is also concomitant OSA. So obesity has been shown to be an important risk factor for OSA. So this is the data we published from Chulalongkorn University, in which we studied at the bariatric surgical clinic, and we demonstrated a very high prevalence of OSA, up to 86% in this population. So in the phenotype of OHS, there is also a OHS predominant OSA component. These phenotypes tend to have long-lasting apnea and hypopnea with insufficient post-respiratory events of increased ventilatory compensation. And that's from mainly the reduction in the respiratory drive, from reduction in the respiratory center function. And these OHS phenotypes, which usually occurs in less obese groups, and tends to have less of the respiratory muscle impairment. They exhibit the long-lasting apnea and hypopnea, but free of REM sleep hypoventilation. And this population tends to respond more to the CPAP. So in summary, obesity can cause respiratory mechanical changes associated with reduction in ERV, reduction in FRC, and increased expiratory flow limitation. They can also have muscle weakness, particularly during REM sleep. And also obesity is associated with increased CO2 production. There is also decreased respiratory drive associated with increased leptin resistance, reduction in mechanical load response. There is also OSA component with inadequate compensation following obstructive respiratory events. All these can lead to CO2 retention. Next, the clinical presentation. So up to about 90% or more of OHS patients also have OSA. So they may present with the OSA symptoms frequently. They can also present with the signs of right heart failure, including pedal edema, plethora, scroll injection, engorged vein, low P2, and low baseline oxygen saturation. They may also initially present with acute on-top chronic hypercapnic respiratory failure. For the diagnosis, so this is the recent ATS practice guideline on OHS. So this is the first question. Should serum bicarbonate or oxygen saturation rather than PaCO2 be used to screen for OHS in obese adults with sleep disordered breathing? So the recommendation is in patients who has high pretest probability for having OHS, they suggest to measure PaCO2 from the blood gas rather than measuring the serum bicarbonate or oxygen saturation levels. However, in patients who have low to moderate probability of having OHS, you can use the serum bicarbonate, in which if the level is less than 27, the clinician might forego measuring PCO2. However, if the level is more than 27, you should confirm by doing arterial blood gas. And they did not recommend to actually use oxygen saturation to decide whether these patients would have OHS or not. This is the criteria according to International Classification of Sleep Disorder. You have to meet all those three criteria in order to have OHS. You have to have PCO2 greater than 45. You have to have obesity, meaning BMI greater than 30, and you should exclude other causes. And generally, we recommend to perform a sleep test or PSG with the CO2 monitoring to check for sleep hypoventilation. And OSA is usually present. If they have OSA2, the patient should be diagnosed with OHS and OSA. And arterial oxygen desaturations is usually present, but not required for the diagnosis. This is the criteria for sleep hypoventilation. So you have to have at least one of these criteria. One, there is an increase in the arterial CO2 or surrogate more than 55 millimeter mercury for at least 10 minutes, or increase of 10 compared to the awake supine values. And you need to also have the value greater than 50 for at least 10 minutes. And this is the staging for hypoventilation in obesity from 0 to 4. 0 means they're only at risk, meaning they have BMI greater than 30 and they have OSA, but no hypercapnia. For stage 1, they start having a little bit of OSA and hypoventilation during sleep. However, they were able to be fully recovered during sleep. And they actually have the same morning and evening PaCO2 level. For stage 2, they start having more of the significant hypoventilation during sleep. They will have this intermittent hypercapnia, in which if you measure blood gas in the morning, PaCO2 level will be higher compared to the evening, and the serum Barkov starting to be greater than 27. And for stage 3, then you have hypoventilation as well, meaning you have sustained hypercapnia while awake. And for stage 4, then you actually have sustained hypercapnia plus cardiometabolic comorbidities. For the treatment, I will start with the chronic treatment first. So in order to treat OHS, you have to aim to maintain upper airway patency, improved alveolar ventilation, reduction in work of breathing, and eliminating hypoxemia. These are the types of passive airway pressure therapy in OHS. There is CPAP, there is BiPAP spontaneous mode, there is BiPAP with backup rate or BiPAP with ST mode. And there is also BiPAP with volume targeted pressure support. So let's look at CPAP first. So CPAP is suitable as the initial therapy trial in patients with stable OHS with moderate to severe OSA. It can be considered in some patients after initially stabilizing with the BiPAP. It tends to be less costly compared to other PAP therapies. It tends to require higher pressure of the CPAP, around 10 to 16 centimeter of water, and they can see the change in the blood gas, but it may be slower compared to BiPAP mode. And there is the lack of long-term comparative data with other modes. Next is the BiPAP with spontaneous mode. It is suitable for patients with good drive and ability to trigger the machines. It's less expensive in general compared to the ST mode. And there is also limited comparative data with other PAP modes. And without a backup rate, it might induce central events if not titrated correctly. Next is the BiPAP ST mode. It is widely used in acute and chronic settings. It's the first-line therapy for patients with isolated nocturnal hypoventilation. It can be set to provide a minimum rate or to achieve passive ventilation, meaning you can set the rate higher than the patient's baseline respiratory rate. However, it can induce patient ventilator asynchrony. And it is, however, it's good in the population whose respiratory rate remains low or ventilation is not adequate despite increasing the pressure support. So next is the BiPAP with volume targeted pressure support. So theoretically, it should provide more of the stable ventilation by targeting a predetermined tidal volume, or some machine would target the alveolar ventilation. And it adapts to change in the sleep stage, pressure, and lung mechanics. However, with variable air leaks and persistent airway obstruction, it may reduce efficacy. And it should reduce the need for manual titration, particularly in the center that have limited viability. However, there is no evidence of clear additional clinical benefit compared to other PAP modes. So this is how volume targeted pressure support works. meaning that if the machine did not reach or did not see that targeted volume is reached, then it will slowly increase the pressure support in order to achieve that target tidal volume. So according to the clinical data, CPAP works around 57% in OHS. It tends to work more in the patients who have more severe upper airway obstruction, less sleep time spent with the saturation less than 90%, less severe obesity, and preserve vital capacity. These groups of patients tends to be more effectively managed with CPAP alone. So this is study is an observation study of 29 patients with OHS, and it tends to be more in the severe side, HI 74, and mean nocturnal saturation of 81 with the T90 of 58%. And according to this study, CPAP was able to reduce HI to 12.2 and improve mean saturations to 90% and reduce the T90 to 8.4%. And at 3 months, oxygen PaO2 was improved from 66 to 73, and the CO2 level was reduced from 50 to 43. Another prospective randomized study was performed in patients with OHS, comparing the CPAP and the BiPAP as mode. And they actually exclude the patients with persistent severe nocturnal hypoxemia, meaning the saturation less than 80% for more than 10 minutes, or a CO2 retention more than 10 despite the optimal CPAP. And at 3 months, there was no difference in daytime CO2 level reduction in both groups and no difference in saturation levels. Another multi-center parallel double-blind trial for the initial treatment of OHS, comparing the BiPAP, ST mode, and CPAP. So baseline was also severe with the HI of 82, oxygen saturation less than 90%, around 67%. And they compare these two devices. And basically, there was no difference in proportion of patients with treatment failure after 3 months. And this is the data. So there actually was no difference. Another large multi-center randomized controlled trial in OHS with also severe OSA, HI more than 30, and they compare 3 arms in this study: the BiPAP or the NIV, the CPAP, and the control group. And in this study, the BiPAP or the NIV yield the greatest improvement in CO2 and bicarbonate level. However, there was no significant difference comparing the NIV and the CPAP. However, the NIV or the BiPAP actually seems to have better health related quality of life assessments and spirometric parameters and 6 minutes walk distance. There was a follow-up study, a multi-center open-label randomized control trial with the long-term follow-up study at the mean duration of around 5 years, comparing the CPAP and the BiPAP. And they found that there was no difference in the mean hospitalization days per patient year between 2 groups. Also, the PaO2, the PCO2, and the adverse events were similar between both groups. And there are also new device that can not only adjust the pressure support in order to target the volume. The new version can also adjust the EPAP by using the force oscillation technique in order to adjust the EPAP when they detect the increase in resistance. So this is the study looking at this volume targeted device. They look at these AVAPs compared to the standard BiPAP ST mode. For the BiPAP standard ST mode, the IPAP was set at the level up to 20. EPAP level was ranging between 4 to 8. Backup rate was set between 12 to 18. For the AVAPs, the maximal IPAP range was set between EPAP and up to 30, and the volume was set at 7 to 10 cc per kg, calculated at the ideal body weight of the BMI of 24, with the best setting regarding tolerance and maximally decreasing the transcutaneous CO2 level. And the data actually shows that there was actually a better for the AVAPs in terms of more efficiently decreasing the transcutaneous CO2 level. However, there was no clinical benefit regarding sleep quality or health-related quality of life. There was another study actually looked at the AVAPs also with the fixed pressure support, and then looked at the daytime arterial CO2 level at 3 months. However, this study used strict protocolized titration. So on the left side, this is the AVAPs titration, and on the right side, this is the standard BiPAP titration. However, they use the strict protocol. They start with the EPAP between 8 to 10. They start with the IPAP of 18 20 to 22. And they start with the backup rate equals to the respiratory rate, subtract 4. And then they have the goal of achieving mean saturation more than 88 and the fall of CO2 level at least around 3.7 millimeter mercuries, and abolition of obstructive events. If they did not achieve that, they would increase IPAP by 10% to improve hypoventilation. They also would titrate the EPAP up to abolish obstructive events with the maximal EPAP of 16. So when you compare the data, with this strict protocol, there was no difference between these AVAPs modes and the fixed pressure support. There was also another study also look at the NIV with the fixed pressure, ST mode, and the AVAPs AE. They also use the strict protocol. The protocol is a little bit somewhat is different from the previously mentioned study. So this is the AVAPs AE, which generally automated. And for the ST titration, they start with EPAP of 5 if the baseline HI less than 15, or between 6 to 12 otherwise. And they start with a high pressure support of 12. And they set the backup rate between 14 to 18. And they aim a little bit different compared to the previously mentioned study. They aim for the mean saturation of more than 90%, which is similar to the current AASM recommendation in general, which keep oxygen saturation at least 90%. And it aims to reduce the transcutaneous CO2 level to the level of 50. And they also aim to reduce the morning CO2 blood gases level to be at least 4 millimeter mercury reduction. And they aim for the apneic events less than 15. And if they did not achieve that goal, then they would adjust accordingly by increasing the EPAP at the apneic events, and also increase the EPAP up to 14. If there is residual hypoventilation, they would adjust by increasing the IPAP by 10%. And similar to another study with the strict protocol, at 2 months, these two devices had similar impact on sleep quality and gas exchange. So this is the recent network meta-analysis comparing different modes. And they found that for PCO2 level, the BiPAP with backup rate compared to control, the BiPAP with backup rate tends to be better. CPAP compared to the volume targeted pressure support, the volume targeted pressure support seems to be better. And compared to controlled, the volume targeted pressure support seems to be better. For ESS score to look for sleepiness, it seems like the volume targeted pressure support seems to be the only one that would achieve that benefit. So in summary, the network meta-analysis suggests superiority of volume targeted pressure support and BiPAP backup with backup rate over other PAP interventions, at least for daytime hypercapnia and subjective daytime somnolence. And this is the recommendation for ATS. Then the question number 2, should adults with OHS be treated with PAP? The answer is yes, it should be treated. The question number 3, then should adults with OHS be treated with CPAP or NIV? So with the current data, stable ambulatory patients with severe OHS and OSA and OHS, they should be initially treated with CPAP. For the acute settings, so this is a recommendation for acute settings. So you treat if the pH less than 7.35, CO2 more than 45, respiratory rate more than 23, or a daytime CO2 more than 49, and somnolence, or and no contraindication for BiPAP. And you should avoid giving too much oxygen and targeting the saturation between 88 to 92%. And the starting of the pressure usually between 4 to 6 of the EPAP, and you increase by 1 to 2 centimeters of water to eliminate witness apnea, chest wall products, and snoring. And the IPAP EPAP difference should be at least 6, and some papers said should be at least 10. And you want to achieve the target volume between 8 to 10 cc per kg of the ideal body weight. And you should monitor saturation, vital signs, consciousness, respiratory pattern, tidal volume, and blood gases. And you should treat other comorbidities, try to avoid excessive diuretics, and you should review the use of medication, particularly the sedation. And if they're not improving, you should plan for the invasive mechanical ventilation, and you should plan for PSG later on when they're stable. So according to ATS also, should hospitalized adults suspecting of having OHS in whom the diagnosis has not yet been made be discharged from the hospital with or without the PAP treatment until the diagnosis of OHS is either confirmed or ruled out. So yes, the recommendation is patient who's hospitalized for respiratory failure with the OHS should be started with NIV therapy before being discharged from the hospital until they undergo outpatient workup and a titration the PAP therapy, ideally within the first 3 months after hospital discharge for this hypercapnic respiratory failure. And weight loss should be also recommended. We recommend around 25 to 30% of the weight reduction of their actual body weight. So conclusion. So OHS is a combination of obesity and daytime hypercapnia until ruling out other disorders. Pathophysiology includes alteration in respiratory mechanics, reduction in respiratory drive, and concomitant OSA. PAP is the main treatment option along with weight reduction of 25 to 30%. And PAP should be considered the first line treatment in OHS with concomitant severe and, I think in my opinion, moderate as well. And BiPAP is recommended in OHS with isolated nocturnal hyperventilation. Acutely decompensating OHS should be treated with BiPAP and discharged home with BiPAP. Follow-up PAP titration within the first 3 months after hospitalization is recommended. So thank you very much for your attention.